were in OT, OR or OPD. I was just telling Uma that I should just go and, I will finish Dr. Bhupesh's OPD.
That will
Help
be
him
a great
out.
thing. That will be a great thing. All learning from you, Dr. Paras.
I didn't know. In fact, this is going to be a revision for all of us from you.
Absolutely.
Should we start?
Yeah, sir. So, welcome all to this 16th session of ASG platform where we'll be discussing about diagnostic dilemmas in microbial keratitis by Dr. Bhupesh Bagga, sir. Dr. Bhupesh Bagga, sir, is a renowned expert in the field of corneal disease with a specialized focus on managing complex corneal disorders. He actively engages in both basic as well as clinical research related corneal infections, pioneering innovative pharmacological and alternative treatments for managing these conditions. Dr. Bagga's contribution are widely recognized through his extensive publication records, which is available across various national as well as international journals. He has also been recipient of several prestigious national grants supporting his work for both clinical as well as basic science research. In addition to the expertise in corneal infections, Dr. Bagga is highly skilled in managing pediatric complex corneal diseases and ocular surfaces with over 15 years of experience in the field. He brings a lot of wealth of knowledge and expertise in the practice. Dr. Bagga serves as the head of Ramoji Foundation Center for Ocular Infections, where he leads a dedicated team in providing cutting-edge care and advancing the research in the specialized area of ophthalmology. Thank you, Dr. Bhupesh Bagga, sir, for gracing this occasion and actually helping us revise the corneal infections this time around.
Thank you, Dr. Ganesh. And just two important things that we don't call sir and ma'am to each other, and that is something. And second thing is, it was very a kind introduction. I was feeling literally overwhelmed in front of people like Dr. Paras and Dr. Nikhil. We are just like learning from them. So I will try to justify the time which you have allotted me, around half an hour to 45 minutes. And then we'll generate certain questions to discuss with the esteemed panelist of today. I'd say basically,
I'd like to also introduce our esteemed panelists after you.
Yeah, so yeah, you can go ahead, then I will start.
So we have Dr. Uma Sridhar with us. She is MBBS from GMC Hyderabad and MS from Sarojini Devi Eye Hospital, Hyderabad. She did her senior residency from GNEC, Delhi, following which she did her LVPI Cornea Fellowship and was a consultant at Cornea and Anterior Segment Eye Care, Noida. She is also a DNB coordinator, thesis guide to more than 20 PG students. She has numerous publications in national, international journals. She also has received Best Video Awards in Cornea in DOS Ophthalmic Conference twice, and also has been guest presentations in DOS and won as a resident TP Agrawal Trophy in Cornea for papers for which she was a co-author. Dr. Uma Sridhar, ma'am, welcome to this platform. Thank you so much for gracing this occasion.
Thank you.
Also, along with Dr. Uma Sridhar, ma'am, we have just Nikhil Gokhale sir is there. I think sir has already joined. So, sir had done his MBBS from UCMS New Delhi, following which he did his MD from All India Institute of Medical Science, New Delhi, and DNB in 1993, and senior residency in AIMS, New Delhi, following which he did his Cornea Fellowship from LVPI Hyderabad, has been an observer in Moorfields, London, Queen's Medical College, Nottingham, UK, and Singapore National Eye Center, Singapore. So welcome Dr. Nikhil Gokhale, sir.
Thank
He
you.
has
Thanks.
awesome number of presentations and oration awards, as well as publications in national and international journals. Also, we have Dr. Paras Mehta, ma'am. Ma'am, you can unmute yourself. She has been in the cornea practice for the last 3 decades. And and Corneal Center, Vadodara. After finishing a long-term cornea fellowship from LV Prasad Eye Institute, Hyderabad, she enjoys handling complex corneal and surface cases as well as laminar corneal surgical procedures. She has been a face behind CSI Kera Grand Rounds, having large viewership across India and across the globe. Known for her biennial weekend meet, focused academic meetings on various corneal diseases and surgical techniques received by the cornea specialists across India as well as across the world. She has several publications to her credit and has presented various papers and instruction courses in Asia Cornea Society Group, APAO, SAO, has been a speaker and instructor in AIS annual conference. She did her short-term fellowship from Manhattan Eye and Ear Infirmary, New York, US. She had the honorary medical director to Elmex Eye Bank and Sri Bhaichand M. Corneal Transplant Center, Vadodara. She has served as the president of Baroda Ophthalmic Society in 2008 and served as a West Zone member for EBI and advisory board for EBI. Essentially, she does also wildlife photography. So it's great to have you, ma'am. Thank you for gracing this occasion.
Thank you, Dr. Ganesh. Thank you for having me.
So I think lots of people have already joined. I think 42 participants are already there, and we are expecting more to join in. Meanwhile, I think we can start with Dr. Bhupesh Bagga's presentation. It's difficult for me not to call you, sir.
Okay. Thank you, Dr. Ganesh, for kind introduction, and I would like to thank to provide this opportunity to entire ASG team, and especially to my friend Atul Dhawan, whom I know for more than now 25 years, maybe nearly 30 years from my school time. So today we are going to discuss diagnostic dilemma in microbial keratitis, and why we are discussing it will come to know in my some 50 to 60 slides. And often people ask, what's dilemma in microbial keratitis? You get the microbial report and you start antibiotics and it gets resolved.
नहीं तो ठीक है ना विद हाँ नहीं तुम एक बार भेज दो मुझे और पेंटोप्राजोल जरूर ले लेना.
Okay, can you please mute whosoever is talking?
Right.
Okay. So this is one of my favorite quote, that when we do not see actually but observe, the world is full of obvious things which nobody by any chance ever observes. The same applies when we observe an corneal ulcer, and actually if you see cornea well infected tells you how you observe it, and it tells you that which organism is actually affecting it. Based on your knowledge, based on your experience, and based on the clinical examination, you can pick up most of the diagnosis which should be confirmed by microbiology. So why it is important to have a correct diagnosis? As I was telling, for guiding the protocol-based treatment, for establishing faster visual rehabilitation with complete eradication of infection, And also it is a key indicator for good prognosis. If you're having a correct diagnosis, somebody is talking. Okay. If you are, I'm repeating it if possible. Please mute your mic. So it is a key indicator for good prognosis and to also understand the disease processes. So what to do when corneal ulcer checks in your clinic? Whosoever specialty you are practicing, this entity is going to hit in your OPD. So as in any other disease, it is important and pertinent that to have a detailed history. In the history, it is very crucial to differentiate between the history of acute versus chronic. Why it is important? Because most of the diagnosis can be picked up just by asking this question: from how long you are having this corneal ulcer or corneal infection? Because we know that causative organisms are different in both these acute versus chronic. We know that bacterial ulcers, particularly gram-negative bacilli or gram-positive, certain gram-positive bacilli are causing acute corneal infection versus fungi, few fungi versus acanthamoeba, microsporia, atypical organisms are usually causing a lost chronic history. Similarly, history of treatment is very, very important, and we often miss to take the history of treatment, whether the patient is using on antifungals, antibacterials, and which type of antibacterial and antifungals. Non-specific treatment, which is often we get, unfortunately, in whenever patient is referred to us, and also antivirals. Why this is important? Because if your patient is on this particular treatment and not getting the response, then you can actually thinking about some other diagnosis. And very important in the present scenario is the use of unjudicious or unsupervised corticosteroids. So take a history of trauma, and very important to assess the history of poor ocular surface. Always ask and examine in that way that your surface of the cornea and ocular surface, how healthy it is. If patient is giving history of herpes zoster, patient is having severe dry eye with rheumatoid arthritis, patient is having Stevens-Johnson syndrome or OCP or any other history pertinent to ocular surface, the diagnosis and the prognosis will be different. Use of contact lens, if patient is using contact lens and having a history of even 1 day severe pain and redness, diagnosis is sure shot that you are dealing with Pseudomonas keratitis or dealing with something very virulent type of bacteria. Similarly, history of contact lens, unsupervised, unhygienic, and history of 1 month or 1.5 months with use of corticosteroids, you can actually predict that you are dealing with a case of acanthamoeba keratitis. Actually, in some way, your brain starts thinking in that line. Systemic history, very important, that history of anti-diabetics, use of corticosteroids, oral or use of some immunosuppression, particularly organ transplant patients. Why this is important? Because it changes the natural history of your infection healing. So response to treatment, as I've written that last, because when you take entire history and we are taking the response to that particular treatment, if treatment is not coming in that way, we start thinking out of the box that no, I'm dealing something else other than a routine corneal ulcer. So don't forget a man or woman or person behind the corneal ulcer. A corneal ulcer, whenever it's coming, the moment you ask whether it is unilateral or bilateral, this question itself gives you very important clue towards the diagnosis. If the patient is having bilateral involvement with a central cornea involvement, you are dealing with something which is of systemic interest. It can be associated with severe dry eye, it can be anesthesia, it can be something related to viral or herpes zoster ophthalmicus unilateral when having a central corneal ulcer. Similarly, if patient is having central or peripheral corneal ulcer, if you have bilateral peripheral corneal ulcer, you start thinking in line of immune-mediated peripheral keratitis. Similarly, history of acute, severe, and pain and inflammation versus chronic or no or mild inflammation will give you different diagnostic outline. Similarly, if patient is having one-time episode or having recurrences of episode, as I mentioned before, need to look for adnexa, always lid margin, meibomian gland, lacrimal gland, conjunctival health, fornices. These are important things which we often miss and tend to overtreat in the line of infection. Untreated or multiple treatment, localized or diffuse. So if you are making this way, classifying your ulcer, believe me, you are actually making towards the diagnosis most of the time, and microbiology is only going to help you and to confirm your diagnosis. If it is confirmatory positive or negative microbiology history, this will again give you some clue where you are heading. On treatment, worsening or responded, and as mentioned before, systemically well or poor overall health. So most important thing is, as we all know, is to establish by doing corneal scraping. This is not a rocket science. This is very important, most important way to diagnose. Should scrape from the edge and the base of an ulcer, and very important is to make 2 smears, at least KOH and grams, to confirm it and inoculate medias pertinent to that, bread agar, chocolate agar, SDA, PDA, BHI, and if you're suspecting acanthamoeba, or even if you're not suspecting, we as a protocol inoculate NNA always, SDA, PDA, BHI, and THI. And if you're suspecting some viral pathology, we take it real-time PCR for confirmation. But clinical dilemmas appear when your microbiology is inconclusive, or cases where you are not having enough sample, or sample is not positive or not able to get those samples because of the reason either it is deep-seated or it is not enough sample, and you're not getting sample from the corneal scraping. And even if you are getting microbiology report, but it is not matching with your clinical, it is not correlating with your clinical impression. So other options are available, which I can mention here, which is not still the standard of care, but I think it can be the future of diagnosis by making metagenomic next generation sequencing, use of MARDI-TOF, use of AI-based technology, and also used by CRISPR-based nucleic acid detection of fungi as well as bacteria. So this is going to be future, but not at present. At present, we are still handling the corneal ulcer with the clinical as well as microbiology, and to correlate with these two. So how to approach a corneal ulcer with uncertain diagnosis? I have written 3S, which means scrape, stop the treatment, if at all it is there, so much treatment, and strategize that how to proceed further. Always tend to look entire ocular surface, entire cornea. I'm stressing this because this often we see this type of patients with ulcer without managing the epitrichiasis, without managing the dry eye, without managing the lid margin issues, and they tend to behave differently as compared to normal corneal ulcers. So these are the options when there's no final diagnosis. So first option, you treat based on the clinical features, which we often discuss, and we tell that these organisms behave in the cornea like this. If you're not getting, you can assume a working diagnosis of this particular organism, but that is usually not the correct way. We should have either a protocol of handling this thing, treat as a bacterial as we are following here. If you are getting a ulcer, and scrape it, not getting any organism, we treat in the line of bacterial corneal ulcer with combination of antibiotics, particularly fortified cefazolin along with ciprofloxacin, and follow the patient on culture. If culture is not doing anything, we stop the medication and re-scrape out, trying to find out the organism in a different way. Most common encounter diagnostic and management dilemmas. These I have written, there are so many dilemmas, but these I have written whichever cases are being referred to us for making a diagnosis is like herpes versus acanthamoeba, which is a very, very important, basically 1 or 2 cases daily I am seeing. Non-healing epithelial defects, whether this is really infective or HSV, or we are dealing with some organism which behave like this. Fungal versus HSV, keratitis caused by rare or atypical organism, whether my peripheral cytic keratitis is non-infective or infective, and SPK. This is again a very important dilemma, and many a times this tend to be most important diagnostic marker of your rare organism, which I'll come with some clinical scenario. Now, with this information, I will take you through some clinical scenarios. So like this is patient of mine of 24-year male who came to us with a history of watering and blurring of vision in left eye since 2 months. He was giving history of foreign body which was removed 3 months back. So if you see the cornea, you will see that infiltrate is whitish, having little bit of thinning around 30 to 40% along with radiating descemet folds. And we cannot appreciate, but there were some whitish capies and some endothelial deposits. But surrounding cornea was not that much congested because patient was using corticosteroids 4 to 6 times a day along with antivirals, along with antibiotics, and along with antifungals, as we are getting many times a cocktail of treatment. So how to proceed now? We scraped it, we could not get organism, but that is the dilemma, that if you are suspecting something, you should ask your microbiologist to relook the slide. So we ask to relook the slide, and when we relook the slide again, we saw that unstained bacilli, plenty of unstained bacilli in the grams. And we, as a part of confirmation, we stained with the 20% and we got atypical microbacteria. So if you go through again this picture, this is giving all telltale signs of atypical mycobacteria, which comes like a cracked windshield appearance, deep-seated infiltrate, history of foreign body, 2 to 3 months of duration, and use of off and on corticosteroids, because this gives you waxing and waning response. And that's how we confirm our diagnosis. So retrospective wisdom, whenever patients coming like this feature, trying to rule out, discuss with your microbiologist and confirm atypical mycobacteria. It was grew also. And finally, we started 2.5% amikacin, and patients started getting response in 1 month time, 1.5 month time, the ulcer completely resolved. This is another patient who has a history of 8 or 9 months with a history of pain, redness, photophobia, but not of that much severe. Conjunctiva was not congested, but a little bit of chemos, but pressure was some 30s or 35. We're seeing stromal haze, stromal edema, whitish diffuse infiltrate. And as we know that whenever we are seeing this entity, which is not responding to conventional treatment, because most common differential, as we being taught and we tell to everybody, if this type of picture comes, diagnosis is herpes simplex stromal keratitis or herpes simplex endotheliitis, and patient should get steroids and patient get response. But on steroids also, if your patient is behaving like this, very important organisms to rule out is microsporidia. And in that way, you are not getting enough sample by corneal scraping. Many times we get it by deep scraping, but sometimes we are not getting. So that time we tend to do corneal biopsy. So that's how you make a strategy that if a patient is using 8 to 9 months corticosteroids, antivirals, not getting enough response, what are my differentials for this particular infections? And top priority is coming a microsporidia. You tend to do biopsy and establish it. Similarly, this patient also having fuzzy infiltrate, whitish infiltrate along with the pigments. And these pigments are basically pigmented KPs. And the clue was the pressure was high, history of 8 to 9 months. So we establish by doing corneal biopsy. I would show a brief video of here how we take a corneal biopsy. You should take away from the visual axis on the active infiltrate. It is like creating a flap. I will try to make it a little faster. So here I am making the flap of the anterior stroma because by infiltrate was a little deeper, and try to take the infiltrate. This is the important to scrape at the base as well as under the flap, and taking this quadrant and send for histopathology as well as microbiology. So take this sample and send it. Don't forget to send histopathology because most important part of diagnosis for microsporidia is histopathology. We confirmed with the microbiology and histopathology that this was microsporidia, and treatment, as we are not discussing going in detail of in this class. So treatment is primarily surgical or medical treatment. Another patient of having a stromal haze referred to us with a diagnosis of query PUK or query toxic keratitis with a patient history of giving around 1.5 months. You can see some stromal haze, a dry looking infiltrate, and stromal haze is not very clear in this picture because I try to zoom on the center of the cornea so that posterior part is little hazy, the peripheral part is little hazy. So the patient was managed in the line of PUK because there's no organism on that time and never scraped in detail. So we started on steroids, and as we started steroids, patient started worsening. When patient referred to us at the time, this was the clinical picture. So retrospective wisdom again, when we saw this infiltrate, which is looking like a dry whitish infiltrate, and if you see closely, if I can use my pen, these are the fine, very fine stromal feathery tentacles, or you can say tentacles around this infiltrate, which is basically we see in one organism, which is called as pythium. So whether we are dealing with pythium, we confirmed with microbiology again, and it was actually pythium keratitis. It was presenting as a PUK. We published this paper. We saw almost 8 to 10 cases where pythium was presenting as a PUK. So now we know that one of the close differentials of PUK is pythium because we see guttering, we see fuzzy infiltrate, we see tentacular extensions. So the important or learning from this is keep your eyes open when you're seeing something. Do not blindly say that PUK and start treating a line of corticosteroids. This is a clean board case for me. A 5-year-old baby coming history of 2 months with the infiltrate in the center and history of off and on use of corticosteroids with little bit of photophobia. As you can see, the surrounding conjunctiva is quiet. So no obvious thought of any infection. But the only thing was these white dot lesions. So in the back of my mind was whether this patient is having some trauma because giving history of trauma, some deposits are there. So we started giving tapering of corticosteroid because patient was on steroids and asked patient to come after 3 weeks with no change in symptoms. So when no change of symptoms, it's a red signal. We should take the patient for EUA and corneal scraping, we lifted the flap and took out all these whitish deposits. It came out to be nocardia. We started treating with amikacin and patient actually responded very well. You can see the congestion came because we stopped steroids. We started amikacin and patients start having photophobia after that. But finally, it responded nicely. So the learning is something unusual. If you see, don't just make a garbage diagnosis of herpes simplex keratitis or some dust or some toxic keratitis. Try to dig it out and finalize your diagnosis by doing corneal scraping. Another entity which is commonly missed and diagnosed as a microbial keratitis is this. When you're seeing this patient having a well-defined edge, having a descemet folds, having whitish infiltrate, with surrounding cornea is relatively acellular, with some ghost scars and deep vessels, with iris atrophy. Most common diagnosis is coming the HSV keratitis. So we always tend to scrape it, and after ruling out the infection, started antivirals along with after 1 week of corticosteroids, patient started responding and completely finally responded. We got the confirmation by IFA and PCR positivity for HSV. So this is the diagnostic way how we make a diagnosis of NSK. When you're having whitish granular anterior to mid stromal infiltrate with overlying epithelial defect, presence of ghost scars, presence of neurotrophic cornea, vascularization, keep a close differential, first differential of NSK, but scrape it to rule out other possible microbial infections. And if you are getting do not start antibiotics, start antivirals and closely follow the patient and see the report of IFA and PCR if you are having your lab is supporting you. Otherwise, with the response with antivirals and corticosteroid, you can make a diagnosis because this is a purely essentially clinical diagnosis. So coming to one eye opener case, this patient came to us with a history of 1.5 months with a stromal infiltrate with having whitish KPs. And whenever this type of presentation comes to us, used to came out, I saw this patient almost 11, 12 years back. That close differential is either we are dealing with HSV or we are dealing with fungus. Because we were never seen at that time fungus behaving like endothelitis or fungus behaving like endothelial KPs, we started this patient with antivirals as well as corticosteroids. And to give us more doubt, patient started responding as well. So this is 1 week, 2 weeks follow-up, completely resolution of the infiltrate. We were sure that we are dealing with HSV. But after 6 weeks of treatment, when we are tapering, when patient was on tapering course of corticosteroids under ACV, he came in the emergency with a worsening of infiltrate along with hypopion. So we do not know what exactly happened. We scraped it, we got fungus, and that was basically a sign where we realized that fungal also can present like this. Are we dealing a mixed infection? That was one of the differential, but are we dealing with the pure fungal cases presenting like a endothelial or involvement like presenting like a KPs? This patient, we did PK and finally did very well. But after that, whosoever case came like that, we make a protocol that we'll do either confocal ruling out fungus or do corneal endoscraping, confirmation by this microbiology, and then only use corticosteroids. So this is again a similar patient. We were in a dilemma whether we are dealing with fungal or viral keratitis. So we again did the endoscraping, trying to figure it out whether this is fungus or HSV. But when nothing came out, we gave a therapeutic trial of antivirals and under close observation added corticosteroids, and this patient actually responded very well. So there are the two patients having almost clinically similar, having whitish KPs, having stromal edema, clinically fungal, responded to antivirals, clinically fungal but responded to antifungals. So after this, we were actually in a condition where we are seeing this type of picture, do AC tap, do endoscoping or do confocal, which is a very, very important tool to confirm when you are focusing on the posterior stroma, you will see some fungal filaments. But the story is not so easy. This was looking like a fungus, and we on scraping, we got fungal-like filaments, started antifungals, and patient worsened. We relooked the slide, smear again. These were actually aseptate. And as we know now, this was story some 10 years back when we used to confuse with the fungal filaments versus pythium. And we started this patient on antifungal, patient worsened. After that, we now know that what are the features which are differentiating between the fungus as well as the pythium. Finer tentacles, whitish raised infiltrate along with guttering, with poor response to antifungals, favors towards pythium, versus feathery extensions, more endoexudates and more of fluffy infiltrate is more of fungus in the initial phase. Only we can differentiate in the initial phase. When they both worsen, it is very difficult to differentiate between these two. Whenever you have doubt, try to establish by closely looking your filaments. Both are different because they are septate, they are aseptate, they are broad and ribbon-like, having a thicker, broader, they are thinner and having a septate. And very important is the clinical features of pythium keratitis, which we establish based on our experience, the fine tentacular extensions along with guttering around the infiltrate, which is of whitish color. These are the few features which we have published extensively of pythium. So based on that, whenever you have feeling a tentacles-like extension, pinhead lesions, and patient is worsening on antifungals, do not miss this entity, although very rare as compared to other fungi, but very important because the treatment is entirely different, 180-degree different. One needed antibiotics. We know that pythium doesn't have ergosterol, that's why we need to treat with antibiotics along with but by the fungal need antifungal treatment. So that's how we make this strategy for ruling out pythium by confirmation by microbiology, as well as by culture, by zoospore production, and by PCR. So this was again a case of fungal looking like keratitis, but we got aseptate filaments. We started treating a line of pythium, but only after 3 days, we got confirmation that this is not fungus. This is having a cottony colony, and this patient was actually confirmed as a mucor. So one other differential of aseptate filament is when your patient is having infiltrated along with the aseptate, you tend to rule out, although rare, much rarer, but confirmation by culture. Both cultures are different, whitish colony. That's why the importance of culture confirmation in the microbiology is important. This patient received natamycin and completely responded after that. So I was talking about SPKs. So these are the 3 scenarios which are the most common scenarios we see encounter. So if you are having a raised coarse lesions with a history of around 1 to 2 weeks with conjunctival congestion along with papillary and follicular versus subepithelial lesions with a history of acute red eye beforehand versus no congestion, recurrence history, multiple course, multiple lesser as compared to the first, raised with no conjunctival congestion. These 3 differential are there: microsporidial, adenoviral, and thyroxine. They are confusing to each other, and many times we get mixed with adenoviral with microsporidia, not very common, having a mixed infection, but I have seen few cases where both were there and microsporidia also presenting as subepithelial, but most commonly, these are the how we differentiate in these 3 entities. But not all SPKs are, or all dendrites are HSV or microsporidia. Like this patient was having 20 days history of severe pain and having few SPKs here, few pseudodendrites here, and patient was using lubricants. When we came to us, we actually stepped up lubricants. At the time, SPKs were increasing. We didn't bother to do any scraping, trying to figure it out that this might be some patient of dry eye or toxic keratitis, but why unilateral? We never thought of that. Patient lost to follow up after that and being treated with corticosteroids and mixture of other treatment. When he came to us after 3 weeks for having ring infiltrate. And at that time, we realized, based on our retrospective wisdom, that this was actually an earlier presentation of acanthamoeba, which we confirmed on corneal scraping. And after this patient, we actually tend to, because patient received corticosteroids, it behaved very badly. You can see that who came like this became like this and very difficult to manage after that. So it's earliest diagnosis, which is actually important in all the organisms. So that's why this is important to learn to pick up. After that, we know that earlier presentation of acanthamoeba can be like this or can be just like an anterior infiltrate. We try to rule out by confocal or by doing scraping. We tend to pick up early radial keratoneuritis, early infiltrates, early dendrites by doing all these. Even if there is no epithelial defect, we are having a high degree of suspicion to pick up acanthamoeba keratitis. But not all rings are acanthamoeba. So this patient was having 2.5 months with having almost ring infiltrate and sent to us to rule out acanthamoeba. Having a white K piece, we were actually thinking that this patient might be having acanthamoeba, but the degree of conjunctival congestion and the pain was very less. So we figure it out by our protocol, by using scraping, by doing confocal, repeat confocal 2-3 times, admitted the patient. Patient was on antifungals, we stopped everything, and finally we could see that nothing came out to be positive. Then other differential of ring infiltrate was diffuse endothelitis of HSV. We started this patient under antivirals along with repeated confocal because we have burnt our fingers all cases. And finally, the patient actually started responding, and on serial follow-ups of now more than 2 years, now we know that this patient was actually having complete clear cornea and responded nicely to our treatment. But we should always having a high degree of suspicion in these conditions. Like this patient, when presented to us on steroids, was having 20/80 vision, having diffuse edema, and all diffuse hazy infiltrates, hazy edema, along with KPs. First differential, we always teach to always learn that it can be acanthamoeba. So at presentation, this was suspected to be HSV stromal keratitis, stepped up steroids and came out to be diffuse age, and finally worsened. It was a ring infiltrate, which finally became epithelial defect and worsened with hypopyon, and we scraped it, we got acanthamoeba. So if you see these two cases, which are presenting almost like a ring infiltrate and behave differently, this was this confocal feature. You can see beautifully aligned acanthamoeba cysts in confocal. So always look for subtle signs, as there was no corneal signs, but if you see the superior, there are some arcane-like features, and this was missed. Inferiorly, also some infiltrate, along with the severe pain this patient was having, treated on corticosteroids, and finally came out to be acanthamoeba. When it came to emergency in an early ring infiltrate, we started treating a line of acanthamoeba by doing scraping, and patient responded with a corneal scar. So these are the few differentials of ring infiltrate. All types of causes, infectious versus non-infectious, can behave like a ring infiltrate, bacteria, fungus, protozoa, or virus. And this is the approach we should take when you're having a history of pain, acute onset, use of corticosteroids. We should rule out acanthamoeba. Is having a history of trauma, acute and painful, even pythium and fungal can present like a ring infiltrate. HSV endothelitis can present like a ring infiltrate. Toxic keratitis or chemically injury induced also can present like a ring infiltrate. Steroid infiltrate also we have seen in particular collagen vascular disorders. On examination, never forget to to see all these subtle features, AC reactions, keratitis, limbitis, and each feature is going to take you some diagnosis, particularly stromal edema and severity, white and pigmented KPs, and edges of the ring, whether they are hyphated or round or thinning. So protocol is use your microbiology as much as possible. Use imaging technique to confirm the deep stromal infiltrate. If not possible, you don't have confocal, do corneal biopsy to confirm, and then only use corticosteroids or other treatment, or refer the patient to a better place where they can handle a different or take some second opinion by anybody else, even if they can be your colleague or senior. By repeat scraping and confocal, you will not lose anything. You can make a confirmed diagnosis. So based on this 45-minute talk, I can say some diagnostic pearls. All dendritic lesions are not HSV. All SPKs are not dry eye or exposure keratopathy. And specifically, all ring infiltrates are not acanthamoeba. There are certain other differentials, other features which you need to keep in your basket to fill and make differentials. All pigmented KPs with edema are not HSV. Fungal can present as an isolated endothelial body. So don't start steroids unattended. Atypical organisms need to be suspected in unusual response. Imaging techniques should be used proactively wherever it can be used. Scrape, scrape, and scrape. This is the mantra of ruling out infection. If you have doubt, to get the best possible sample and establish the diagnosis. With that, I would conclude my talk with the invitation to all of you to join the conference, which is coming on 31st, from 31st October to 2nd November. This is the 5th edition of Bugbusters, where we discuss absolutely infection, nothing else. Thank you very much.
Bhupesh, you have talked about confocal. What about the role of ASOCT? Have you used that a bit?
Yeah. So yeah, I specifically not put it. Actually, we have certain features on ASOCT to rule out or to differentiate between the HSV, acanthamoeba, microsporidia, and to also to assess that depth. But these are adjuvant features. You cannot make any confirmatory diagnosis on these features. But if you're having a doubt, the ASOCT can be one of the Am I audible?
Yes.
Yeah,
Yes,
so
sir.
it's
Please.
one of
You're
the
audible, Bhupesh.
yeah, so one of the additional tool to keep it in your armamentarium, because we have done studies to differentiate between the acanthamoeba and HSV, and acanthamoeba and HSV and microsporidia. So features are definitely there, which can be used in differentiating these infections.
So like in HSP, when diffuse endothelitis, now, and you can't see the KPs on slit lamp, we have done ASOCT, and when we find KPs, we'll say, okay, this could be endothelitis. So what were your features of microsporidia, which you were finding on that?
Yeah, so first thing is you will find pigmented KPs and even white KPs sometimes in acanthamoeba as well. So only by seeing the KPs, it is to differentiate between these two are not possible. The only feature which I find, if KPs are underlying the edema and exactly following the boundary of edema, you tend to have more of endothelitis, versus if you are having only localized in the central cornea pigmented blotchy KPs, those are you find in acanthamoeba. In microsporidia, you won't find much of edema. Thickness is not changed in the cornea, versus HSV. You will find 600, 700, sometimes depends on the involvement of the cornea. But in microsporidia, you will see anterior to mid-stromal haze without much of change in the edema. and you will find whitish KPs. And along with the chronicity, these KPs become pigmented, as you saw in one of the patient. So these are the features in OCT.
Found some powdery kind of deposits, which it's not very typical of HSV. So these we found stromal microsporidia, very powdery looking, as you said, anterior midstromal. And one has to doubt it basically to think about it. Otherwise, we had patient where we kept giving steroid, and finally landed up at SN, and Meena did some scraping and she said this was stromal microsporidia. We don't see with those very often here in North India, like the stromal microsporidia basically.
Yeah, that's thank you, Dr. Uma. So this is very important, as I showed in two of the cases. We're actually coming almost 5 to 6 months or 8 months on steroids, because when you give steroid, patient becomes symptomatically better as compared to fungi, which actually worsen. So this doesn't worsen, but this becomes a little silent. So your symptoms become masked. You will have granular, I call it cloudy infiltrate, because it looks like a whitish cloud. If you zoom this infiltrate, you will actually looking like this as if you are sitting inside the cloud, and they are whitish infiltrate, cloudy infiltrate, without vessels, without scar, as compared to HSV, and without much of posterior involvement. Most of the involvement is in the anterior to midstrom.
So how do you treat them? Do all cases of stromal microsporidia need the TPK, or they respond to some
So we recently published one paper in Journal of Ophthalmic Inflammation, medical management of stromal macrosporidiasis, where we have treated 7 cases of stromal macrosporidiasis based on the in vitro data of with the fumagillin 0.007% along with voriconazole and
is it
oral
available?
yeah, let me just complete. So 0.007% along with voriconazole and oral albendazole combination. And fumagillin is not commercially available. We have to formulate it. So we get it raw powder from Sigma, and we prepare in our pharmacology laboratory to make it 0.007% and treat these patients. It take a lot of time, 6 to 7 months to completely resolve. If you see that paper, so median time of resolution is around 6 to 8 months along with voriconazole. And all these patients actually received albendazole oral as well for 1.5 months. And these patients actually completely resolve. We have 5 years of follow-up of 2 or 3 patients, and 1 patient. Most other patients have completed their 1.5 year follow-up, and they actually didn't recur. And 1 patient where I did the corneal PK, optical PK, because the central involvement was there. That patient also is not having any evidence of microsporidia and the histopathology. So it suggests that actually there was no microsporidia left when biopsy initially was having plenty of microsporidia. Yes.
Voriconazole alone help if you don't have access to
We do not know, Dr. Uma. Voriconazole we have tried before, and there are 1 or 2 anecdotal case reports of its use of stromal macrosporidiasis. But if you see the in vitro data, fumagillin, voriconazole, albendazole, they all have been found to be efficacious against microsporidia, but the most common, most effective was the fumagillin. So based on that data only we got it, and we try to combine with, because we do not know what exactly is going to help. So we treated but out of 7, 4 patients actually received only fumagillin, not voriconazole.
Dr. Bhupesh, are there any predictors where you would like to intervene surgically in these stromal microsporidial keratitis? Because the cases which would not respond to medical management, that is fine. But there are early predictors where you would like to intervene early on, like.
Yeah, so I would say all of my cases where I have treated are smaller cases, not very early, not very late. Their median size of infiltrate was 4.5 mm and not beyond that. And they are all till the mid stroma level. It's because we do not know how deep the drug is going. And also, if patient is having diffuse infiltration, means 7 to 8 millimeter deeper stromal, hypopion is there, and also having poor followability, not able to afford the drug because this drug is quite expensive to make it, even if we do not charge from non-paying sort of patient who are not able to afford, but still this drug is very expensive and need cold chain of maintenance. We have to keep this drug in the freeze and the freezer, basically -20 with the upper part of the freeze. So all these things, if you're not there, that's why we could recruit only 7, 8 patients in 3 to 4 years, because not all patients actually going for this. And this is expensive drug, around 2 to 3,000 rupees per bottle comes. So in this is not there, and we know that surgically the outcome is not that bad of all of cases which we have done, more than 72 cases we have analyzed in therapeutic grafts, and out of them only 4 actually recurred back, rest all not recurred back, and the survival is also equally good as optical graft. So yes, so probably that is the reason. But cases which I managed were actually willing, and 2 of them were having a renal transplant, and so they were not willing for one more transplant. So that's the reason when we have medical therapy available, why not to try it?
So what kind of patients get stromal microsporidia? Is it the immunosuppressed or the generally the farmer types, or what?
So patients are actually out of many patients whichever I analyze, there's no 100% some predisposing factors are available. And initially we were thinking that might be they are immunocompromised. So I told only few of them are having, well, like these 2 are having renal transplant and on immunosuppression. And 2 are actually very old age, 80 plus patients having a bilateral microsporidia. And I do not know, there no as such we could figure it out. And one patient was having chronic uveitis on immunosuppression for that. So there are definitely some role of immunosuppression, and only one patient we could figure it out. That patient came 5 years back with the proven macrosporidial superficial keratoconjunctivitis, and now he's having a stromal keratitis. So whether that has caused, we do not know the species, but we know that both are different because both look different in under microscope. So we do not know actually, Dr. Uma, that what are the exact predisposition of these patients, but there is no history of trauma. You will get it. Only history is chronicity and severe chronic use of corticosteroids, which comes first, whether they were having HSV or now injudicious rule of corticosteroids have given them, or because there's no animal model of microsporidia which to tell that what exactly is causing them.
So it's always epithelium intact, is it?
Epithelium not always intact. Few patients are actually presenting, which were actually a mimicker of fungal keratitis. I have not shown here. So that was a clean board case for us where we didn't get anything, having fluffy infiltrate, started on antibiotics, and finally after 1.5 months of follow-up, we could scrape and patient was not having a response when everywhere the microsporia. So because it doesn't cause that much of neutrophilic response, that's why this doesn't present like a frank bacterial ulcer. It is actually a low grade, low virulent, low organism. That's why the ulcer doesn't happen. But as we are discussing, Dr. Paras also in the last 2 weeks back, so there was a
Yeah.
case we were having she was having, and I told that many times. Initially, you are thinking that biopsy is the only answer, but if you scrape
Yes.
it, take out the epithelium and dig it out, you will get macrosporia and the subepithelial also. So now I do not subject my patients for biopsy for confirmation. I scrape it and ask my fellow to dig it out and give some reward for them, that okay, you find out microsporia, and also to confirm with confocal as well. There are certain signs which we are trying to find out. Can we see these organisms under confocal?
Yes,
Uh,
we did do deep scraping and got the microsporidia on smears positive. Like,
Yeah.
you know,
So it's a
and we
great speculation that we have seen as a general ophthalmologist, varying complex situations. I would like Dr. Nikhil also to come in and tell us his comments and his experience about the different pathologies that sir has already described.
I would just say that as a general ophthalmologist, I think 90% of our ulcers are either bacterial or fungal. So I think the general ophthalmologist probably will very rarely see some of these cases which sir is seeing, because he is sitting in a tertiary care institute. And I think the most common dilemma for a general ophthalmologist is still to distinguish bacteria versus fungi. And I think a simple scraping and just doing grams and KOH is something that possibly all of us could either do in our clinic or try to sort of, get it done locally with any pathologist or microbiologist who is very interested in seeing those slides. And I think that can make a lot of difference to our patients, because empirical treatment is something that is probably not going to work very often. The other thing, of course, is that we are trying to treat everything with moxifloxacin, right from conjunctivitis, placebo treatment, viral. And when it comes to bacterial ulcer, sometimes we need to understand that fluoroquinolones may not work and we need to use fortified drops, which probably we have to, it's not a big deal, but there's a lot of inertia among general ophthalmologists in making these drops. So
भूपेश
I
ने
think we
बताया
all
था ना
have to learn how to make these drops, and probably we'll be able to treat our patients better. The other thing, of course, as you know, I follow a general principle that if there is no diagnosis, I will not use steroids. So I tell the patient as well as my other friends that if I'm not sure what I'm treating, I would not, as far as possible, use steroids empirically. I think a lot of the cases which sir has shown are basically generated by all of us because we empirically use steroid without understanding the pathology, and slowly the patient tends to get worse, although he may be symptomatically better with steroids. So that is again another problem. And I also see a lot of patients where they're diagnosed as viral, they're treated with steroid, but it's not viral. So as you were saying, either they're microsporidia or there's something else which is there, which we tend to diagnose. My other very common and general principle is that if there is a epithelial defect, I would normally avoid steroid as far as possible from my side, unless I'm dead sure what I'm treating, or especially in what looks infective, because uh, very often, again, sometimes somebody diagnoses them as necrotizing stromal keratitis, starts steroids with antiviral, and only after a week or 10 days you realize this is a fungal abscess. So some very small things, I think, as we need to all take care as general ophthalmologists, so that at least we don't create iatrogenic complications. And I think simple things of scraping and trying to figure out bacteria versus fungus will be possibly adequate to treat 9 out of 10 ulcers that land up into our clinic. And of course, when we have very difficult cases, we have LV Prasad, Shankar Netralaya, and all these institutes to help us. But when we send it to them, we should be sure that we are not creating trouble by sort of misdiagnosing or incorrectly diagnosing. And I think nowadays, because of availability of photography, most of us can take pictures and share with our colleagues, if we are not very sure of what we should be doing. But again, one important thing is that when we discuss these things, when we take opinion, I think we need to have a proper and a detailed history, which should also come along with the picture. Sometimes I see WhatsApp groups where a photo is sent and somebody says give steroid, second person says give fungus, somebody says this is viral. So I think just a picture doesn't speak for itself. We need to definitely, add up all the relevant information, history, and a detailed sort of backup should be there. And it's not good to just comment on a picture on the face value, because all of us can go wrong, however experienced we may be. So I think we have to learn how to better, sort of interact with each other. Otherwise, sometimes we may be misguiding our juniors by just looking at the picture and saying, this is viral, just give this thing, or this fungus. So I think we all have to see how we practice and how we can, improve the outcome that we give to our patients. So there's some small things that I thought might be useful.
The other thing, Nikhil, I feel is, sorry, Ganesh, that inadequate treatment is very common. Sometimes you're giving 4 times Natamet, 4 times voriconazole, 4 times this, 4 times that. And then a lot of private practitioners and even our patients ask, aren't you going to give oral? So they are being treated like typhoid and not like corneal ulcer. So most of our patients come with Taximo twice daily, then something else and something else. But the topicals are given 4 times and 4 times, and afterwards a cocktail. So one basic thing is avoid cocktail. Second thing is oral, where it doesn't have a role in bacterial ulcers. It's not typhoid. And where oral antifungals has to be given, there are very specific indications. And inadequate dosage is the most common thing that you see. 4 times this and 4 times that. That is not sufficient. That hourly, half hourly, that is the initial treatment. I think that message is the most important, which needs to go across.
Also, the other thing is, I think we need to learn to document, because it's only by seeing the ulcer every day, unless you draw it or you take a picture, you'll not realize how an infiltrate is resolving and changing into just an inflammation there. And how do we learn to taper drops? So I've seen somebody starting 1 hourly drops, which goes on, even till the infection is gone, and now you have a non-healing surface. So to learn all these changes which are happening in the eye, in the cornea, I think we have to learn to document correctly. And just sometimes to document or to draw a diagram, maybe, something that can help us learn correctly and try to observe the various changes that are happening in the cornea, which we will otherwise miss unless we draw. Or you have to take photographs serially and, put them all across and see what is happening. Otherwise, we are liable to make judgment errors and, not really know what's happening.
I've seen your beautiful
To
diagrams,
add
Nikhil,
to
in your
that,
patients who follow. We have some common patients, I think, and I've seen your very nice diagrams with you, this one. I have actually put them
yeah,
in
I
my
just
book
wanted to have
also.
one more comment here.
Sorry.
Yeah, I just wanted to have one more comment here. We have a lot of fellows and comprehensive ophthalmologists also attending this seminar. So it is not very difficult to do, a 10% KOH examination. Like if you learn how to get familiar to that, and if you can have a microscope in your OPD. I am a solo practitioner, and I have been doing this from beginning of my practice, because many a times, even if you don't have very good trained microbiologists, they will say they are not very accustomed to see ocular microbiology. They will miss few organisms here and there, because they are managing organisms in abundance, so our samples are very scanty. So if you have seen your KOH preparation by yourself, then you know that at least you are treating fungal, or you are treating a non-fungal ulcer. So at least basic line of management becomes very clear. And if it worsens further, maybe based on that, you can again take help of the laboratory investigations and all. But to have a basic microscope, have grams and KOH done in-house would help you for almost 80% of your patients to reach to a proper diagnosis and have a targeted therapy for that particular patient. Am I right, Dr. Bhupesh?
Adding on to the question, ma'am, just once you scrape, you have already answered in the forum, I guess, but what should we actually do? Where should we take the sample, in what medium, and how should we transport it? And before we get a result out of it, should we start on certain drugs at least? as ma'am already said that 4 times drop may not be the right way to go. So a guidance, say you are confused between a fungal ulcer and a viral ulcer, which may be there, and you're not sure what to start. But meanwhile, at least till you get the results or the patient visits a corneal surgeon, you have to start something. What all things we can at least start?
Actually speaking, for that, primarily one should have a clinical picture and a primary, impression in mind, whether we are dealing with classical. By and large, I mean, 80% of the patients would not have these kind of, difficult diagnosis like acanthamoeba or microsporidial stromal keratitis. They would be either bacterial or fungal by and large. So it is important to have a clinical impression, whether you are dealing with whether it is a very confirmed infiltrate with fluid hypopion, which varies with the position of the head and all, and the symptoms are very acute and the history is very short, probably you are dealing with bacterial. Similarly, if it is fungal, there would be a feathery, so one should be very familiar with the classical pictures of some basic microbial keratitis, and based on that one can start empirical treatment. But I would still say a step ahead that it is important to do a little bit of scraping. There is no rocket science. Do a scraping from the leading edge of the ulcer and the base of the ulcer, and at least take smears, make smears like the grams and KOH, and at times even a saline wet mount. It is not very difficult to get familiarized with the microbiology. We have done it in our MBBS, and you just have to get yourself reoriented to it. And most of the time, you would be able to differentiate microbial keratitis, whether you are dealing with bacterial or whether you are dealing with fungal. And then your management would be a lot more easy. Then you don't have to give a cocktail therapy or, start something and then switch over to something else.
Yeah, Uma ma'am, your comment.
Yeah, actually, Dr. Ganesh, basically, like Paras said, I also have a microscope in my room and I always do KOH myself. But of course, for a general ophthalmologist, it is good to have a basic idea of what it is looking like. Like Bhupesh said, the history, a farmer, vegetative matter, all these things, feathery hyphae, raised edges, plaque-like appearance, pigmented infiltrate. It could be fungal. You scrape, you send to the lab, but when you see the feathery raised hyphae, everything, and it could be fungal and you have scraped it. Yes, we have been taught in LVP also that don't start antifungal without seeing fungus under the microscope. But yeah, when you have a doubt, send it. Maybe wait for a day and then start your antifungal. But if you're starting and you're sure, put it 1 hourly. Before you are sure, you can give antimicrobials. I don't know if Nikhil, Paras, and Bhupesh would agree that you can give your, you said you are probably, one does not give moxie just like that. But yes, there is an infiltrate, there is a hypopion. You give your atropine 3 times a day and your moxie 1 hourly, send the scraping to the microbiologist. And when they find the fungus, start 1 hourly your natamycin. So I think you get a basic idea how it is. If you are going to treat ulcers, it's a very good idea. If you're buying a 15 lakh phaco machine, you can get a 30,000 microscope, keep it in your OPD and see if you are really interested in treating, if you're treating microorganisms here in your thing. So I know it takes a lot of your chair time. Your patients are not okay. They sit next to your cataract patients and say, I'm not getting better. So, but if you're genuinely interested in treating bacteria and fungus and all the corneal ulcers, don't mess it up. Don't start antifungals. Don't start a cocktail. If you're confident, yes, scrape, send to the microbiologist. Just start antibacterials in the beginning. And then when it's proven fungal, start antifungal. If you're not sure, send. So don't start a cocktail like, throwing darts in the dark and hope for the best. So that is one thing one would say, yes, be happy with your cataracts and your LASIKs. And if you see a bacteria, if you see an ulcer, and it's a small ulcer, obviously you're starting your fluoroquinolines 1 hourly and then following up within 48 hours, not healing, scrape, like Bhupesh said, scrape, scrape, and scrape. But if you are not confident, just send them ahead. Do not start a cocktail. Do not start inadequate treatment. Do not mess up the clinical picture. That's what I would say. Right. And
Dr. Prakyat is cornea.
my question to all the panelists is, and Bhupesh sir, what is the yield of scraping that we have generally? So, I mean, in my practice, it's not more than 60%. So the question comes back to when I'm suspecting uh, viral with the super added fungal, or is it just a fungal? So how do you really make sense out of it? Because I'm sending scraping every second day and I'm not getting a fungal hyphae. So uh, so now and I am suspecting fungal. So what should my approach be?
See, by the time your scraping goes, it gets dry, Prakyat. That's why when you scrape in your OPD and you put a wet mount, KOH wet mount, you get a far more yield than when you are going to scrape and put it on a slide and send it to microbiologist. So many times I scrape, I find fungus, and the same slide goes to the microbiologist. By the time it reaches there, it's pretty dry. So there, unless it grows in culture or they see it in gram stain, it's lost. So wet mount is extremely important. So you would probably, if you keep a microscope in your OPD and you take a scraping and see it immediately, and with a KOH, you will get far more, you think it is fungus, you will get a fungus. If it is a big infiltrate, if you are not getting a fungus with yourself, then of course you look at other diagnoses. It could be anything else. It could be a differential, could be a nocardia, could be atypical, could be anything. If it is you are scraping, seeing immediately. If it is a large infiltrate, you're scraping and you think it is fungal, you will get fungal. And if you don't, then it's not fungal, you know? So that's one thing I think. I don't know what the other panelists think, but by the time you send it to the microbiologist, it gets dry. So, or your microbiologist says, put the cover slip, put some nail paint around so that it doesn't go away, or they will see it in gram or Ginsa. Yeah. So
Yeah.
I would say as a cornea specialist, keep a microscope in your OPD. That would
I
be my
totally
advice.
agree with Dr. Uma because we have even picked up microsporidia on wet mounts. Microsporidia, you can even pick up acanthamoeba on your wet mounts. So most of the time, you will be able to reach to your diagnosis very well. It's just that you have to get into a habit of, screening the slide before it goes to the microbiologist. As a cornea specialist, definitely it is highly recommended.
So,
Right.
Prakhat, thank you for asking this very practical question actually, and very relevant question for everybody whosoever is interested to rule out. I'm very happy that you are sending scraping, and we all are for that only. So, my thought is, my question to you is, if you are suspecting fungus and your microbiologist is not able to find out fungus in the smears, then how do you manage those cases? And what are the outcomes of those smear negative cases in your practice?
Sir, to be very honest, I go by my clinical suspicion, even if I don't find a, a fungal hyphae. I send cultures along with it, and my protocol is the microbiologist is just like we share a wall. So, so we prepare the slide on
Okay.
the slit lamp with
Okay.
KOH, and it goes just right beside, so
No,
it
no.
doesn't get
My
dry.
question, my
So
question is, what are the outcome of those cases where you
more
are
than
suspecting and you are not getting organism and the smear,
so
and
in
you are
those
still
cases,
treating in line of fungus in the
yes,
line of your clinical things,
yes,
and along
and
with antibiotics.
along with antibiotics, but generally, sir, by the time the patient visits a place like the center, I know, like, we have different centers and all of our fellows are working in different centers. For me, it is mostly a patient comes to me after, say, 6 weeks or 4 weeks of therapy already done, and that is the mixed therapy with a lot of oral, like Uma ma'am said, which is inadequate. Like, it's neither on the lines of bacterial nor on the lines of fungal. So when I look at the patient, I just take down that history, but I am looking more towards the appearance and the symptoms that the patient has, the chronicity, and those kind of algorithms like you shared, you know uh, how much
So,
steroid, organic injury, and all, and I go by my clinical suspicion, and most of the times I am right. I continue with the fungal treatments. I don't, I mean, either I give bacterial or I give fungal, not like giving concentrated drops along with uh, six, like 1 hourly antifungals also added to it. So I usually err on the side of either it is a fungal or is it a bacterial. And hypopion helps a lot. In my practice, I've seen it's one of those signs which works well in deciding whether it is a bacterial or a fungal ulcer. So I am most of the times right, but my point is that I am still not. I mean, I have also learned and always wanted to, go by the scraping. But practically, if I don't get the yield on day one, I am going to start the patient on something. And if I keep the patient on antibiotics while I am clearly seeing that it looks like a fungal ulcer, all my intuition is saying that it's a fungal ulcer. My question is practically how long will I have to wait and keep scraping the patient in my private practice till the point when I start an antifungal?
So maybe before Dr. Nikhil and Dr. Paras answering, I was just thinking that this is very important point, because if you see the clinical signs, they are very important, in particularly fungus if you are seeing. And in India, if you blindly say that my ulcer is fungus, you will be more than 50% is correct without seeing the clinical signs. So it is not like that we are treating on clinical signs only, but the whole purpose of all the exercise and the class is to be more of evidence-based clinic rather than only based on the signs and symptoms. And your thought, if somebody next come then and say, my thought is doesn't look like, just give combination of treatment. And I have plenty of referrals and they all say, this combination of treatment works in my hand. So it doesn't work that this is a combination of treatment is work from your hand. It's fine, but what are you actually treating it? And you do not know that how much damage on the cornea is going to happen when you're giving a mixed treatment. So if you are not getting organism, I will say that's the opportunity for you to improve the corneal scraping, as Dr. Uma was pointing out, rather than believing that your results are negative or somebody's else, because I can understand there are more than 100 people are listening. It is opportunity for everybody to improve the result of scraping yield rather than saying that my results are negative and I know is going to be negative, what to be given. So take it as a study and trying to improve the way Dr. Uma is doing, or private practice Dr. Paras is doing and Dr. Nikhil is doing, and how they are getting better yield than others.
So that brings me
Dr.
back to my
Bhupesh,
question.
they can send their microbiologist to LVPI for 1 or 2 day or maybe 1 week observation, and they can pick up lot of points to make sure that from a smaller, amount of scraping also,
So
they can get the positive
it's
results.
always a welcome thing, and I would say that
Absolutely.
we are
Because
having.
Prakyat, if you cannot spend so much time on that, maybe you can make sure that your microbiologist is well oriented to handling these samples. Isn't
1 or
it?
2 weeks orientation
My
is quite.
question, sorry to interrupt, sir. My question is still unanswered. What I was asking is, how much percentage of scraping should compose? Like, when would I start thinking that, okay, I am doing good enough scraping? That was my question to begin with. So the answer is 100%, 80%, 60%. Like, what should be a benchmark for a private practitioner or for all of our fellows to think that, okay, this yield is means that our process is okay?
Can I answer that?
Yeah.
Though it
Yeah,
may not be from the, data which can be compared with any of the institutes, but being in a private practice for such a long time, at least I would say ranging between 70 to 80%, we are able to recognize the organism, especially the fungus, on smears, the KOH or a saline wet mount. So if your scraping is good and you have made the slide properly and you are well trained to look at these organisms, at least this is my experience in so many years. Like, in many a times we take the picture and send it to a microbiologist when they say that kuch nahi dikhta hai. you you show them that there is, so many fungal, filaments are on that. So you should be able to do that.
I completely agree with Paras.
Yeah.
No, but Prakyat, what happens, is that if you are seeing patients 6 weeks after a cocktail therapy, your microbiology positivity rate will be definitely lower than somebody who is seeing them on day 1 or maybe day 5 or day 7, because by then they have not been treated, or they've just come a fungal ulcer who walks in, you can just see the slit lamp and, make a quick diagnosis as well without really any scraping. But when they have been treated for 1 month or 2 months, sometimes things are deep. There is toxicity, there is medicamentosa, and there is, we don't know what's happening. So in those situations, I agree, or very often you may not get anything positive. So, I mean, that frustration will always be there. But when you see them early, I think that is what we need to do, is to educate our colleagues that if they can't handle them, better to send them earlier than later. So sometimes
Or
somebody
else,
sends a total ulcer to me. I say, go and do evisceration in that surgeon's hands. They say, I don't want to do anything now. So it's something like that, like they're sending you end stage, possibly nothing will often be positive and very difficult to treat unless you have something like an organism which is untreated. Like he said, there is acanthamoeba and you're just giving a cocktail, then you might still have a positive result. But if it's something which is half treated, it may not come positive. So but we have to
you
try our
could
best.
even put these patients on drug holiday sometimes, 24 hours, 48 hours. You put them off the medications and then scrape, and then your, yield would be better.
There is one more interesting question in the chat box which says that wanted to know if there is topical losartan can be tried for corneal opacity or scarring, or for that matter, any SPKs that we come across post the healing. What kind of treatment would you prefer?
Is losartan available here? Topical? I tried with the powdered losartan, didn't work. So I don't know about the topical aspect.
I think after the publication, a lot of people have tried to formulate it. I think RP Center is also trying to get a topical formulation working for the angiotensin receptor blockers, but so far we don't have anything that reduces scar uh, in India, at least, I think.
So
Actually, Prakyat, Shine was doing his work with Dr. Funderberg on mesenchymal stem cell therapy, which was supposed to reduce corneal scars. I sent a patient to him, but I think it's still in the experimental stage. So, the mesenchymal stem cells apparently might work and reduce the scars. But actually speaking, also the collagen remodeling that occurs when you see your ulcer patients after 5-6 years, the scars have actually thinned down and the patient sees better. So, one I feel should not, when you tell the patient kacha hai abhi bhi the scar, you are not in a hurry to do anything, to do a falc or salc or whatever you want to do, or a dalc. You wait for a while. I think the cornea remodels quite a bit over a period of time. So I
Yeah,
don't know about losartan.
I think one
The
important point, Dr. Uma, because somebody asked losartan and you said this point. So I've seen particularly kids or younger patients who are actually 20 by 100 or 20 by 200 become 20 by 25 in the on follow up of 1.5 year, 2 years. So this car modifies and so need not to be so much on that scar and try to modify it. And I do not know about the trial which published. That was the only question which was having in my mind, that why we are actually, I don't know, this is not going to change the natural history. And patients of fungal ulcers and particularly Pseudomonas ulcers, if you see these two organisms, their ulcers are not going to have much of visual defect because probably they are not causing that much of disturbance. And even if they are there, they do well with the glasses or some sort of contact lenses.
So, one more question, like we see in a post-operative cataract patient sometimes recurrence of herpetic endothelitis. So anything that can be done pre-operatively, intraoperatively, or post-operatively, or to be taken care of in such patients? Dr. Nikhil can.
No, basically, if you have post-operative this endothelitis, as you said, usually they respond to steroid with antiviral. But before we come to that diagnosis of endothelitis, I think we need to rule out other entities which may cause corneal edema following cataract surgery. So sometimes if you have a clear cornea on maybe in the first week or 15 days, and then suddenly you get corneal edema, I think we have to rule out other things. For example, there could be a small fragment at 6 o'clock or a small nuclear fragment, or some of the other things. And also, if you see a lot of keratic precipitates, low grade endophthalmitis is again something that needs to be ruled out before we just jump to that conclusion. But if it is endothelitis and there is no telltale evidence, so there are some patients who may not have any old history of viral or something like that. But otherwise, in general, if I operate a patient who has a well documented viral history, I normally put them on oral acyclovir starting maybe 2 or 3 days before surgery to starting maybe at least a month till your steroid dose is frequent or more frequent, and then I stop the acyclovir prophylaxis like that. So one is you can give oral prophylaxis, but if you do diagnose it, the other thing is if there is an option, you can do PCR for a AC tap to be, and figure out whether there is any HSV. But again, those things are very limited in most places. So
Oral acyclovir, how much? 400 milligrams BD?
yeah, prophylactic dose is normally what I would give if we are doing cataract surgery in a quiet eye with a previous history of, say, some viral or some scar or whatever it be. And then monitor these patients more frequently post-operatively to see that there is no sort of problem, because they are more likely to get epithelial problems as well, because they have some neurotrophic component, or they might have toxicity to NSAIDs, epithelial defects, breakdowns. So all these things are more common, so you have to be more watchful.
So one more question about valcyclovir versus acyclovir. What do you prefer in your practice, Dr. Bhupesh, Dr. Paras, Mehta?
Because acyclovir was being used early on, I mean, unless the patient is showing any resistance to oral acyclovir, my first drug of choice would be oral acyclovir. And if compliance is a problem, then probably I would switch over to valcyclovir.
I think we had a wonderful discussion regarding most of the topics which are commonly also seen, and as well as the complex conditions that we have seen in Bhupesh Bagga's presentation. The take-home messages, if sir can just tell us what we should actually take home when we are seeing, just enumerate again the 5 facts probably would help us.
Thank you, Dr. Ganesh. Yeah, it was a very good discussion, and as always, we learn from discussion about microbial keratitis, and certain questions always come to the mind. So take home with the discussion from the discussion can be, first is do not use any drug, even quinolone, blindly to the cornea, because and try to see and establish clinical diagnosis by using clinical clues. Second is, if you are making some clinical working diagnosis, trying to establish and confirm and correlate with the microbiology. And if they are not correlating by corneal scraping or doing by culture or by this thing, then to try to figure it out, what are the reasons why they are not correlating. And if they are correlating, well, you are right. But if they are not correlating, do not keep giving antibiotics blindly on the ocular surface, on the cornea, because that will actually confuse the picture. And most importantly, do not use corticosteroids without any 100% surety that you are dealing what organism is. Because although rare, but they are not uncommon to see organisms, which I have alluded in and mentioned in my discussion, because they are the cases which we are seeing referred to as something else and come to something else. And lastly, which is their most common organisms in our practice is still bacteria and fungus. Trying to learn picking them by simple microbiology observation by spending some 50,000 rupees on microscope and doing KOH or grams. We are offering everybody to come and learn these simple microbiology skills by doing regular workshops, by doing regular training, by SOS training, by discussing. We are always available for help. Thank you.
Thank you so much, Dr. Bagga. Closing comments from Uma Sridhar ma'am.
Wonderful presentation, Bhupesh, as usual. And I hope you make your Bugs Busters hybrid so that we can attend. I mean, I've never attended your Bugs Busters. So it would be very useful. And I think all our fellowship training at LVP as and with Savitri Sharma ma'am and Usha Gopinathan ma'am has really, I don't know, I don't think we've been made microbiologists, but as cornea specialists, I think we are exposed to a lot of infections, and hopefully, Prakyat, you will not come across after 6 weeks of futile treatment, but you will get. I generally feel if the microbiologist cannot treat, just send them forward. It's okay. I mean, if it's not healing in 48 hours, please send them forwards, and don't let us get limbus to limbus infiltrates with overtreatment, with cocktails and steroids and oral antibiotics and such things. I think a lot of preventive care, not giving steroids and advising the pharmacist not to give a combo of antibiotic steroids would help. And I hope preventive medicine would be more useful than, and one basic thing in medicine we learn is if you make rare diagnosis, you are rarely correct. So like Nikhil said, basically they are bacteria and fungus and to some extent virus, but of course, the rarer organisms may be there, but yeah. So I think happy bugs busting, as Bhupesh would say.
Thank you, Uma ma'am, for your wonderful comments. Paras Mehta ma'am, your closing comments, ma'am.
In fact, it was wonderful to have great cases shared by Dr. Bhupesh and lot of insights into that. Like, I mean, everybody has to keep in mind the other aspects when you are treating a corneal ulcer, like, looking at history of, previous trauma or systemic associations or surface problems and all. So all in all, a cornea specialist has to, or even a, comprehensive ophthalmologist has to look into a lot of things. And that would allow you to treat your patients in a much better way. And obviously, when you cannot really handle these situations, maybe best way is to refer to another person and keep learning from that person. Not necessarily you just send away the patient and just forget about that patient. I would say that have a link between that person and you so that next time you don't miss the same, clinical diagnosis. And as I suggested, Dr. Prakyat, that maybe you can send your microbiologist to a better center for better understanding and training so that you can have more positive yields. And it was so wonderful to have, be part of this academic meet and looking forward to some more also. Thank you, Dr. Ganesh, for having us here.
Thank you, Paras Mehta ma'am, for your comments. I would like Dr. Nikhil for his closing comments.
I would just say that I think we all have to work in the direction of seeing that we have a good microbiologist who is interested in ophthalmic evaluation in our own cities or towns or suburbs or wherever we work. One of the ways of doing it is to, first identify a person who is interested, and then I think if multiple ophthalmologists send their samples to a single person, maybe he has more chance to learn and basically get accustomed to these things. And as Paras said, I think Bugbusters is one place where the microbiologist can have a very good opportunity to interact with ophthalmologists. And I think I would also feel that maybe if they visit there or visit LVP, we should encourage them to do that so that they will learn, and then, things will become easier for us. So it's a long journey. I've also sort of, when I came from Hyderabad, I remember I talked to Dr. Savitri that nothing comes positive. And from that, I started from scratch like that. And then slowly we have to see how to set up our things in our own practices when we leave institute. So when you are in the institute, everything is always positive. You have support of so many colleagues. All our reports, if you are in doubt, I would ask Madhukar. We had so many other great cornea people there, and we would discuss and treat the patient. But when you are in your practice, you are alone. There is nobody to sort of discuss with you. So I think it's a journey that all of us have to go through and try and see how we can develop better support systems around us. It's not only microbiologists, pathologists, rheumatologists, all these sort of things we have to develop, which come very easily in an institute, but very difficult when we are in our own practice. But I think we all have to strive to work together, and only then we can sort of, get better results in these very difficult situations. Otherwise, it's very frustrating.
I agree with
Thank you.
Nikhil. I remember going to LVP,
Nikhil.
collecting Alcyon blue from the pathology lab, and then giving it to the pathologist and saying, is this macular dystrophy? So I think the institution training helps you. But as you said, it's a difficult ball game finding a microbiologist, pathologist, rheumatologist who think that eye is part of the body, which is a very difficult thing to find.
So thank you everyone for joining us on this wonderful session on cornea. Thank you, Dr. Bhupesh Bagga sir. Thank you, Dr. Uma Sridhar ma'am, Dr. Paras Mehta ma'am, and Dr. Nikhil Gokhale sir, and my colleague, Dr. Prakhyat Roop, being a moderator. We have a wonderful academic cell of Dr. Kaushik Tripathi, Dr. Mayank Sharma, and Atul Dhawan, who have been trying to actually collect these wonderful classes, which can be helpful for many. And we will have this online video as well available shortly afterwards, from which many people can also be benefited. Thank you for once again joining us. Looking forward to more such meetings. Good
Thank
night.
you. And I think
Thank you.
I
Thank you,
really
Ganesh.
am amazed that Dr. Ganesh, you being a retina person, you had the patience to hear all of us for such a long time, more than an hour, I think. That's really hats off.
It's always interesting and not
Commendable.
Thank
commendable.
you.
Thank you, Dr. Ganesh,
you.
Dr. Roop, and Dr. Bhupesh. Thank you.
Thank you,
Thank you.
everyone.
Thank you. Bye-bye. Good night.
Good night.